Welcome to The Explainer. Today, we're taking a deep dive into the human brain to unpack a really specific, highly complex neurosurgical procedure. It's called the endoscopic third ventriculostomy, or ETV for short. We're going to skip all the textbook fluff and translate some pretty dense clinical data into a complete, easy-to-follow guide. We'll get right into exactly when to use it, when to avoid it, and what happens when things go wrong in one of the brain's most delicate surgical corridors.
So, to make sure we don't miss a single crucial detail, we're going to follow a very structured clinical framework today. We'll start with the indications for ETV and the contraindications to consider. Then we'll move through potential complications, overall success rates, how to calculate the ETV success score, and finally post-ETV clinical outcomes.
All right, let's jump straight into Section 1, Indications for ETV. Let's talk about patient selection. Knowing precisely when to deploy an ETV is absolutely the foundation of clinical success. It's primarily indicated for 4 very specific scenarios. First up is obstructive hydrocephalus. This is sort of the classic use case, right? It allows us to bypass a fluid blockage directly by creating a brand new pathway. Second, it's an absolute game changer for managing shunt infections. Think about it. If you have infected hardware, an ETV allows us to completely remove all that foreign material while simultaneously treating the hydrocephalus, so we don't subject the patient to a dangerous spike in intracranial pressure. Third, for post-shunting subdural hematomas, the shunt is actually removed, or at least tied off, before the ETV is performed, just to restore that intracranial balance. And finally, it's a vital option for slit ventricle syndrome. This is an incredibly challenging condition where the ventricles are so chronically collapsed that traditional shunt catheters just constantly fail and get occluded.
Moving on to Section 2, Contraindications to consider. Basically, who should we avoid doing this procedure on? Understanding the boundaries of this procedure is just as critical as knowing when to use it. Traditionally, communicating hydrocephalus is a strict red flag. It's a hard no for ETV, mainly because the core issue isn't a physical blockage, but rather a failure of fluid absorption somewhere else in the brain. But, there's always nuance in modern practice, right? ETV is occasionally utilized for normal pressure hydrocephalus, or NPH, though I should mention that remains a pretty controversial exception. You also always have to weigh the scales of pre-existing conditions. Any underlying pathology that's known to have a low baseline success rate acts as a relative contraindication. It forces the surgeon to ask a tough question. Is this stoma actually going to stay open?
Next up is Section 3, Potential Complications. Let's really unpack the risks involved here.
Because we're operating in incredibly tight, delicate anatomical quarters within the third ventricle, even the most minor deviations can cause profound clinical issues. We can break these down point by point. First, the walls of this ventricle are literally formed by the hypothalamus. So, if the endoscope injures the hypothalamus, it can actually trigger hyperphagia, which is this extreme, abnormal, and totally uncontrollable drive to eat. Second, just below our surgical target is the pituitary stalk. If that gets damaged, it can disrupt the patient's entire hormonal axis, potentially leading to things like diabetes insipidus or amenorrhea. Third, we also have to watch really closely for transient palsies of the third and sixth cranial nerves. If those are affected, it will severely impact the patient's eye movements after surgery.
Beyond the nerves and hormones, the vascular risks are severe and potentially life-threatening. Just millimeters below where the fenestration is made sits a highly complex vascular network. We were talking about the potential for catastrophic injury to major vessels like the basilar artery, the posterior communicating artery, or the posterior cerebral artery. Now here's a fascinating but honestly terrifying detail. There is a specific risk of a traumatic basilar artery aneurysm forming due to thermal injury if a laser is used to make the stoma. If uncontrollable hemorrhage does happen, there's a crucial clinical pearl to remember. Keeping a fixed endoscope sheath seated just distal to the foramen of Monroe can actually act as a pressure escape valve. It allows blood to safely egress outside the skull rather than instantly compressing the delicate brainstem.
Let's move to Section 4, Overall Success Rates. It's time to look at the actual data by pathology.
So across the board, if you just group all ETV patients together, the baseline success rate sits at roughly a coin flip. It's about 56%. But actually, that aggregate number is pretty deceptive in day-to-day clinical practice. If we isolate the absolute ideal patient pool, specifically those with non-tumoral aqueductal stenosis, that success rate skyrockets. We're talking anywhere from 60 to an incredible 94%.
That massive contrast really perfectly illustrates the extreme importance of patient selection. The absolute highest patency rates belong to patients with previously untreated acquired aqueductal stenosis. On the flip side, if we look at the infant profile, success rates there are historically very poor. Why is that? Well, because infants often lack a normally developed subarachnoid space. So even if the surgeon flawlessly creates the ETV and successfully diverts the cerebrospinal fluid, the infant's brain simply can't absorb it and the procedure inevitably fails.
Conversely, we absolutely have to recognize the 5 specific pre-existing conditions that cause success rates to completely plummet down to a dismal 20%. Let's go through the clinical reasoning for each one. First, the presence of a tumor simply alters the fluid dynamics. Second, a history of previous shunting reduces the brain's overall ventricular compliance. Third is a previous subarachnoid hemorrhage, which essentially scars the absorption pathways in the brain. Fourth, previous whole brain radiation. Now, as a quick caveat to make sure this is clear, focal stereotactic radiosurgery doesn't carry the same confirmed drop in success, only whole brain radiation does. And finally, if significant structural adhesions are visible when perforating the floor of the third ventricle, the chances of that stoma staying open just drop significantly.
This brings us to Section 5, the ETV success score. How exactly do we predict these outcomes?
While surgeons don't just guess at these odds, they use a validated mathematical tool called the ETV success score. It calculates exact probabilities based on 3 main clinical categories. Let's break down the math real quick. It's pretty neat. First up is age. Infants under 1 month score 0, while patients 10 years and older get the maximum 50 points. Second is etiology, or the cause of the condition. Tough conditions like post-infectious hydrocephalus or myelomeningocele score super low, between 0 and 20, while aqueductal stenosis scores a solid 30. Finally, previous shunts. Having a prior shunt history drops your score for this category down to 0, while being completely shunt naive gives you 10 points. You literally just tally those 3 columns up, and your total, out of a maximum of 90, gives you the precise percentage chance that the ETV will survive 6 months without failing.
Finally, Section 6, post-ETV clinical outcomes. Let's look at the real-world results.
So what do those calculated scores actually mean in practice? Well, the extremes are pretty straightforward. Scores under 40% mathematically mean a very low chance of success, which steers you away from doing an ETV entirely. Scores over 80% outright beat shunting from day one, making ETV the obvious choice. But the intermediate scores, the ones between 50 and 70%, present a really fascinating clinical paradox. Initially, these intermediate ETVs actually have a higher failure rate than a traditional shunt. But if the patient manages to make it through those first 3 to 6 months without failing, the mathematical balance flips completely. ETV then becomes the superior option, heavily favoring the patient over the long-term lifetime of the condition.
To put a real-world pin in this theory, one major series tracked in our source data achieved clinical improvement in 76% of patients. That was 72 out of 95 individuals. But this really highlights how complex things get when you're managing real human biology. That successfully treated group actually included 6 patients who had to undergo a second ETV procedure after the first one closed. And even wilder, 3 of those patients had partially functioning shunts that the surgeons deliberately left in place during the ETV. It just proves that even with robust, hard predictive scoring, individual patient management is incredibly nuanced and often requires hybrid approaches.
We have the deep clinical data, we have the calculated percentage scores, and we fully know the potential for catastrophic vascular risks. But applying all of this to a living, breathing human brain sitting on the operating table remains a profound clinical challenge. When a patient sits right there in that intermediate risk zone, how much weight should a surgeon give to a mathematical formula versus their own surgical intuition and hard-earned experience? It's a huge question. Thank you for joining me on this deep dive into endoscopic third ventriculostomies. Keep analyzing, keep questioning, and I'll see you in the next explainer.